Hello and good evening, everyone. I am Dr. Heather from Exam Expert. We welcome you all in this session. Hope you all are fine and in good health. Can you hear my voice?
Yes, of course, Dr. Hassan. Hello, Dr. Hassan.
Yes, Dr. Helmi. How are you?
I'm fine. How are you?
I'm also good. Alhamdulillah. So, dear members, can you hear our voice?
Yes.
Yes, we can.
Perfectly all right. I think, Dr. Helmi, we should start. Meanwhile, the other candidates can hear. There's already been.
Okay, Dr. Hassan. Kindly, can you turn off your mics, please?
Yes, please. There's a mic option in front of you. Either using it on the mobile or laptop. There's a mic. If it is green, then we are able to hear your voices, and if it is orange, it means it's mute. So please, during the session, try to keep it mute. We would like to know that mostly students are, appearing in July exam who are in this.
Please. Kindly mute your mics. Please turn off your mics. All candidates can hear us. Hello?
Yes, I can also hear your voice. Of course.
She said she doesn't need.
Manu, please mute the students manually because we have teachers who's like so. Yes, Dr. Helmi, over to you.
Okay, Dr. Hassan. Hello, everyone. Welcome to the Mid-Exam Expert. Today, we will have a session, small session, and we are going to discuss how to interpret ABG and how to interpret Urodynamic graph. First of all, I'm Dr. Mohammed Halmi. I'm an instructor and a mid-exam expert. I work as a lecturer and gynecology, Zagazig University in Egypt. Can you all see the presenting slide or not? The welcome slide. Can you all see the welcome slide?
Yes, we can.
Okay, good. Can you hear my voice well?
Yep.
Yes.
Okay, good. Now, kindly, please turn off all of you turn off your mics, and when we start discussion, you can turn it on, please. Our first topic today is how to interpret arterial blood gases, or the ABG. This is a very important topic, and actually it's now fixed in every exam that you are going to face a question, maybe even 2 questions related to this point, how to interpret arterial blood gas result. And the good thing that is actually most of the questions which come for part 1 MRCG is so direct and easy. No sophisticated questions, no complicated questions, but they should be learned very well. And I think it's one of the direct questions that you should take the marks of this question, and you should lose the marks of this question. To interpret ABG, we are not using cameras, okay? Please turn off your cameras. I'm not using also the camera. I'm using this only the PowerPoint presentation. Please turn off your mics, turn off your cameras, please. Thank you. So we have few steps to help us how to interpret ABG. The first thing is to detect first whether the pH is normal or not. We have 2 disorders. We have acidosis and we have alkalosis. So the first thing is to know whether the pH is normal or not, and if it's not normal, whether it is acidosis or alkalosis. And as like we are investigating a case, we have 2 suspects in this case. The first one is the CO2, and the CO2 is the representative of the respiratory part or the respiratory system, and the bicarbonate will be the representative of the metabolic system. And we are going to analyze the results of the CO2 and the bicarbonate and see which one of them is normal and which one is abnormal. And then we are going to match the results of the CO2 and the bicarb with the results of the pH, as we are going to see later, to know whether is it a condition of respiratory disorder or a metabolic disorder. Then the next step, when we diagnose the condition, whether it is respiratory or metabolic, we are going to investigate the other system. For example, if we have a respiratory disorder, we are going to check the metabolic part. If there is a trial of compensation from this part or not, if there is a trial to compensate the disorder or not from the other system. Also, we are going to know this from the coming examples. Then at the end, we are going to check the saturation of the oxygen and the partial pressure of the oxygen to know whether there is hypoxia or not. So these steps are collectively how to analyze the ABG. So the first step, how to analyze the pH. The normal pH of the blood is about 7.4, but also we have a range. The normal range is 7.35 to 7.45. This is the normal range. When the pH of the blood falls below 7.35, it is considered acidic. And of course, when it rises above 7.45, it's considered alkalotic. So this is the first step, to know either acidosis or whether there is alkalosis. So this is our first step. Then we are going to analyze the CO2, which is the representative of the respiratory system. The normal CO2 level is from 35 to 45 millimeter mercury, and we should know that when the CO2 rises above the normal level, it will lead to acidosis, and when it decreases below the normal level, it will lead to alkalosis. So after analyzing the CO2 and know whether it is normal or abnormal, we are going to check step number 3, the bicarbonate. And the normal level is from 22 to 26 milliequivalent per liter. And we know that the HCO3 is the representative of the metabolic system. And if the bicarb increases, it will lead to alkalosis. And when it decreases below the normal level, it will lead to acidosis. Now this is the most important step. We know the pH, we know the CO2, we know the bicarb. What about matching the results of the bicarb and CO2 to the results of the pH? For example, if we have acidotic pH and when analyzing the CO2, we found that the CO2 level is high, and we know that when the CO2 level is high, it will lead to acidosis. So CO2 will be considered the guilty arm now, the responsible one for this acidosis, and the condition would be called respiratory acidosis. But if we have another condition, for example, that the pH is alkalotic, and we check the CO2 and we found that the CO2 is normal, and when we check the bicarb, we found that the bicarb level is high, and we know that the bicarb is the representative of the metabolic system, and when it increases, it causes alkalosis. So of course, the disorder here will be metabolic alkalosis. This will be more clear when we solve examples and questions later on. After we check one system, or after we know that there is a system causing the disorder, we are going to check the other system. For example, we know that when the CO2 rises, it causes acidosis. And we found that the CO2 is high and the pH is acidotic. So the condition is respiratory acidosis because pH is acidotic, and we found that the CO2 is high. Now, after we know that this is the guilty one, this is the responsible one, we are going to check the other one, which is the bicarb. And we are going to see whether there is a change in the bicarb level or not, because it is supposed that as a kind of compensation, as a trial of compensation of this disorder, the bicarb level will try to normalize the pH again to the normal level. So when I have respiratory acidosis, I am expecting that the bicarb, which is alkalotic, will try to increase to try to normalize the acidity of this condition or the pH of the blood. So when I check one system, I should check the other system to know whether it goes in the opposite direction of the pH or not, as a trial of compensation. And at the end, we are going to check the partial pressure of the oxygen and the oxygen saturation to see if there is hypoxemia or not. Mics, please turn off your mics, please. Now, these are the normal values of the arterial blood gases result. These are the normal values. The pH is from 735 to 745. And when, of course, the pH decreases, it is considered acidosis. And when it increases, it is considered alkalosis. Then the partial pressure of the carbon dioxide is from 35 to 45 millimeter mercury. And when the CO2, which is the representative of the respiratory system, increases, it will lead to acidosis. And when it decreases, then the normal range or the normal level, it will lead to alkalosis. Then comes the bicarb, which is the contrary of the carbon dioxide. Its normal level is from 22 to 26 milliequivalent per liter, and when it increases, it will lead to alkalosis, the opposite hand of the carbon dioxide, and when it decreases, it will lead to acidosis. Then we are going to check the O2 saturation, which is normally at the room air from 95 to 100%, and of course, when the O2 saturation decreases, it will lead to, or it indicates hypoxia or hypoxemia. Also, we have another thing which can help us in the interpretation of the ABG, which is called the base excess or the base deficit. And simply, the base excess or the base deficit range is from positive or plus 2 to minus 2. This is the normal range. And when the value of the base excess is less than minus 2, it indicates metabolic acidosis. Metabolic acidosis. And when its level is more than positive 2, it indicates metabolic alkalosis. So the base excess or the base deficit is another reflection or another representative of the metabolic system. And when the values of the base excess is more than positive or plus 2, it indicates metabolic alkalosis, and when its level is less than minus 2, it indicates metabolic acidosis. Now this is to interpret this ABG. We have a pH of 7.27, and we know that the normal range is from 7.35 to 7.45. So this is acidotic pH. This is the first. Now we will check the first R or the first suspect, which is the carbon dioxide, and we can see here that the carbon dioxide level is high, 53 millimeter mercury. This is the partial pressure of the carbon dioxide, and we know that the upper limit of the normal level is 45. So now I have abnormal CO2 level. It is increased, and we know that the CO2 is the representative of the respiratory system, and we know that when it increases, it will lead to acidosis. So CO2 is here acidotic, and the CO2 matches the condition. So the condition is respiratory acidosis. This is my first diagnosis. Then I'm going to check the second arm, which is the representative of the metabolic system, which is the bicarb. And like as I can see here, the level of the bicarb is normal. So still there is no trial of compensation. So this condition is not compensated. This is a case of respiratory acidosis, and it is not compensated by the metabolic system. Now, by checking the O2 saturation and the partial pressure of the oxygen, we can see that they are low, and this indicates hypoxia and hypoxemia. So this is a case of uncompensated respiratory acidosis associated with hypoxia or hypoxemia. So this is simply the interpretation of the arterial blood gases. Now let's try this example. And in the exam, they will give you the reference of the normal levels. Okay, so this is in the exam. We are going to have the reference of the normal levels of most of the lab investigations. So let's answer this example. We have listed here the partial pressure of the oxygen and the carbon dioxide. We have the pH. We have the hydrogen ions, bicarb, excess oxygen concentration. Let's analyze this. You can discuss with me now. He mentioned here that the partial pressure of the oxygen is 108 millimeter mercury, and the normal level is from 90 to 110. So is it normal or abnormal?
Normal.
Of course, this is normal. Regarding the partial pressure of the CO2, it's mentioned here that it is 48 millimeter mercury. So is it abnormal or abnormal?
Abnormal. Abnormal?
Yes, it's increased here. Okay. Now let's check the pH. So first we have a CO2 increased. The CO2 when increased it leads to
Acidosis.
yes, acidosis. Let's check the pH. What is this pH? Alkalosis or acidosis?
Alkalosis.
Yes, this pH is alkalotic. And when we see the CO2, it is acidotic. So the CO2 here is not the responsible one, because it goes in the opposite direction of the pH. So now let's check the bicarb. The bicarb here is
High. Abnormal.
high. Yes, and when the bicarb increases, it will lead to?
Metabolic
Acidosis.
No, the bicarb will increase, it will lead to alkalosis. It's
metabolic acidosis.
yes. So now, yes. So now the condition here, the bicarb is the guilty one. It matches with the pH. So the condition is metabolic alkalosis. And there is a trial of compensation from the respiratory system by increasing the CO2, trying to increase the acidity. I have an alkalinic medium, and there is a trial of the CO2 to increase the acidity to normalize the pH at the end. Another thing that can confirm my diagnosis is the base excess, which is another representative of the metabolic system. As the increase, also the base excess increase, and we see here that the base excess is positive 14. So this confirms my diagnosis as a metabolic alkalosis. Now, when we see the answers here, metabolic acidosis, of course, it is a wrong answer. Metabolic alkalosis, acute with normal oxygenation.
This is also wrong.
Yes, this is the right answer. Normal ventilation with hypoxemia, of course, this is respiratory failure. Respiratory failure, by the way, it is acute respiratory acidosis, so it's wrong. And of course, respiratory failure, the last answer is wrong. So the right answer here is metabolic alkaline with normal oxygenation. This is our first example. Answer this example. Also, we have here the partial pressure of the oxygen is 122 millimeter mercury. It's considered normal or slightly high. The partial pressure of the carbon dioxide
Not showing.
This acidotic.
pH is acidic. Hello?
We can't listen to your voice.
Please wait a while. He'll be back with us.
I can't hear anything.
like we said that we have partial pressure of the oxygen and we have a high carbon dioxide. So we know that when the carbon dioxide increases, it will lead to acidosis. And when we check the pH, we can see here that the pH is
Acidic.
Blue. Acidosis.
yes, acidic. So now we know that the carbon dioxide matches,
pH is
so it's a condition of respiratory acidosis up till now. Now let's check the other parameter, which is the bicarb. What about the bicarb level?
It's normal.
Yes, it's normal. So there is no compensation. And
Yes.
I think the oxygen, we have a normal oxygenation.
Yes.
About the answers, let's check this answer. Is it a metabolic acidosis?
No.
Is it a metabolic alkalosis?
No. No.
Normal ventilation with hypoxemia? There is no hypoxemia here. So no. Respiratory failure, I have two options now. Respiratory failure. Is it acute or compensated with hypoxemia?
It's not hypoxemia.
Acute.
Yes, it's acute. Still no hypoxemia and still no compensation. So it's a condition of acute respiratory failure. And this, of course, is wrong. So here will be acute respiratory failure.
Okay.
Now let's take this example. We have a 33-year-old prima gravida presents to the delivery suite with palpitations, chest discomfort, and breathlessness. The obstetric registrar on call performs an arterial blood gas analysis, and the results are as follows. What's the most likely diagnosis?
She's alcoholic. Bicarb is low.
Now we have this pH. This pH is acidotic or alkalotic?
Alkalotic.
Alkalotic, yes, right. This carbon dioxide is low or high?
Low.
Yes. What happened when the CO2 decrease?
The bicarb increase.
No. What would be the disorder here? Alkalosis or acidosis?
Acidosis.
No, when it decreases.
Alkalosis.
Yes, alkalosis. So now the CO2 matches the pH, right?
Yes.
I have a basic pH. I have decreased CO2, so it is a question of respiratory alkalosis. Yes. Now the oxygen is normal or not?
Normal.
Normal. What about the bicarb?
Low.
Low.
Yes, it decreases. When the bicarb decreases.
Acidosis.
Yes, so this is a trial of, now the bicarb is going in the opposite direction of the pH, so this is a trial of compensation from the metabolic system. So this is the interpretation of this example. I have respiratory alkalosis, compensated normal oxygenation. Okay, so let's check the answers. We have chronic obstructive disease, we have metabolic acidosis, we have metabolic acidosis with respiratory compensation, we have respiratory acidosis, we have respiratory alkalosis. So what is the best answer here?
Respiratory alkalosis.
Yes, respiratory alkalosis. So this is the best answer here. Example, we have a 32-year-old woman present in her second trimester complaining of breathlessness. On examination, her respiratory rate is 14, chest is clear, and she's saturating at 97% on room air. ECG shows normal sinus rhythm. A blood gas on room air reveals the following. The pH is 7.45, the CO2 is 3.9, the oxygen is normal, and the bicarb is also, according to the reference given, is normal. So what is your interpretation now?
pH is high.
pH is high.
Low.
A slight increase in the pH. Okay, let's go step by step. Okay, when you go in these examples or in these questions step by step, you will never lose mark. Don't become so confident and rush in. We have 7.45 is slight alkalosis. Yes, right?
Yes.
Is low.
And we have also
Alkalosis.
yes, and we have also yes. We have here the oxygen, the carbon dioxide is also slightly decreased, right?
Yes.
What happens when the carbon dioxide decreases?
Acidosis.
Alkalosis.
Yes. So it's a kind of respiratory alkalosis. Okay, up till now. Okay. Normal oxygen, normal bicarb level. Now let's check the answers given or the options given. Anxiety,
No.
low tract infection, metabolic alkalosis, normal physiological change in pregnancy, and pulmonary embolism. What will be your answer here?
Anxiety. Change in pregnancy.
Physiological change in pregnancy.
Yes, of course. Normal physiological change in pregnancy, because we know that in pregnancy we have stimulation of centers by the progesterone level, which lead to hyperventilation. This will lead to slight push of the CO2 from the body and slight respiratory alkalosis. So it's a normal physiological change in pregnancy. That can be noticed by that the pH of the blood is slightly, very slightly raised. It's not severe condition. It's a slight alkalosis. And this is, of course, one of the normal physiological which happen in pregnancy. Let's interpret this question also.
It is 5 years.
Step by step. What is this pH?
Low. Low.
Yes, this pH in the normal is from 7.35 to 45, so this pH is decreased. So this pH is
Acidosis.
acidotic. Yes, it's decreased. Okay. Now let's check dioxide. What is this? What about the level of this
It's high.
carbon dioxide?
Low.
High.
Doses.
Yes, it's high.
Okay.
High.
Yes, so it is acidotic. Okay. So my first interpretation will be respiratory acidosis. Okay. The PO2
Low.
the PO2 normal PO2 is from 11 to 12.6 ppa. So it's slightly low. Yes. Now let's check the bicarb. The bicarb level, which is normally 22 to 26, is
Low. Decrease.
Low.
Reduce.
low also. What? So what happened when bicarb decrease?
Acidosis.
Also acidosis. So now we have two criminals here. We have two guilty arms because they both match with the pH. So from those options, the best answer.
Mixed.
Yes, it's a
Metabolic.
kind of mixed metabolic and respiratory acidosis. So
Okay.
as you can see here, when we go step by step, it will be very easy to interpret. Please, sometimes in the exam, you feel confident, so you rush in the answer and you miss something. Please go step by step, and this question inshallah will be guaranteed in the exam. Let's start this scenario. A 35-year-old woman who is 26 weeks gestation goes for walking in a hill, and when she is on the extreme of the hill, she becomes little breathless and has anesthesia in her hands. What is the appropriate acid-base imbalance in this condition?
Carbon dioxide becomes lesser so she
Extreme.
carbon
Respiratory. Respiratory alkalosis.
respiratory
She
alkalosis.
won't have a breath.
Yes, to analyze this scenario, we know that when walking in highlands or in a hill or something like this, there is a kind of hyperventilation. This hyperventilation will lead to wash of the CO2 from the body, will lead to decrease in the level of CO2. So when the level of the CO2 decreases, it will lead to alkalosis, and of course, CO2 is the representative of the respiratory system, so it will be respiratory alkalosis.
Hey.
This is a case of 24-year-old pregnant woman presents with persistent vomiting. She becomes tachypnic, which is the most likely acid-base disorder in this patient.
Vomiting. Metabolic alkalosis. Next. Metabolic alkalosis.
Carbon dioxide decrease होगा.
Yes.
Metabolic acidosis occurs.
Yes, when vomiting occurs, loss of the acid from the body, it will lead to metabolic alkalosis. Okay.
Yes.
And the patient is tachypnic just as a kind of compensation. Okay.
So what? Next metabolic alkalosis is respiratory acidosis.
Yes. No, not respiratory acidosis here.
Okay. Only metabolic to wash out carbon dioxide.
This option is wrong. It's a metabolic acidosis. Okay.
Yes.
Everything metabolic cycles.
Now, we have two disorders of the electrolyte. I want you to know that the hypokalemia and hypercalcemia, the manifestations of both hypokalemia and hypercalcemia. Why those in particular? Because the manifestations of hypokalemia and
It's different.
the manifestations of hypokalemia and hypercalcemia are having characteristic features, pathognomonic features, and they are the most asked two electrolyte disorders in the exam. Of course, the manifestations of sorry. Can you hear my voice now?
Yes.
Yes.
The manifestations of hypokalemia are many, but the most important of those are abnormal ECG, constipation and paralytic ileus, weakness and cramps in the skeletal muscles, and maybe in severe cases it leads to paralysis, chloride wasting, and it can lead to metabolic alkalosis. So these are the most important manifestations of hypokalemia. When we also discuss the hypercalcemia, one of the most important electrolyte imbalances, and actually also an important note that the hypercalcemia is the most common plastic syndrome which occurs with cancers. So many cancers is associated with hypercalcemia, and hypercalcemia is considered one of the most common paraneoplastic syndromes which occur with many types of cancers. Most important of those manifestations are formation of renal and biliary stones, pain, bone aches or bone pain, abdominal pain, nausea and vomiting, polyuria, which will lead to dehydration, also psychiatric disorders, especially depression in 30 to 40% of cases, and anxiety, insomnia, and maybe even in severe cases can lead to coma. Other symptoms, of course, it includes cardiac arrhythmias and also can lead to nocturia and polydipsia. So these are the main manifestations of hypercalcemia. And as I said, that hypokalemia, hypercalcemia have some pathognomonic clinical features. When you check other electrolyte imbalance, like for example hyperkalemia or hyponatremia or hypernatremia, you can find that their manifestations are specific. But for hypercalcemia and hypokalemia, they are so specific. And when you check the recalls or the past exams, you can see that these two electrolyte imbalances can be asked in the exam. So in this case, a 7-year-old woman who is taking a pendroflumetazide, which is a diuretic for hypertension, presents to the GP with muscle weakness, muscle cramps, and constipation. The GP arranges to check serum urea and electrolytes. Which electrolyte disturbance is most likely to be present?
Hypokalemia.
Kalemia.
Yes, of course. When using thiazide diuretics, they are putting diuretics and they lead to hypo. And also this scenario is very common, and it can also come with an ECG trace showing also hypokalemia. So this scenario was asked before about 3 or 4 times in the recalls. As we can see here, the options, the comment, the symptoms are all features of hypokalemia. The patient is taking a thiazide diuretic, a side effect of which is hypokalemia. It's important to have an understanding of all varieties of electrolyte disturbance, their causes and clinical manifestations. But of course, like I said, hypokalemia and hypercalcemia are the most important in those. Take this scenario. A healthy 34-year-old woman had a total abdominal hysterectomy for cervical disease. Routine urea and electrolytes are measured, and the following are shown. We have the sodium is 21, and the normal range is 135 to 145. The potassium is normal. Urea is normal. Create is normal. So, what is the most likely cause to explain this blood test result?
Excessive intravenous dextrose.
Yes, according to the scenario here, we have a patient who just had an operation, a major operation, abdominal hysterectomy, and we have here slight hyponatremia or hyponatremia, and this is a common side effect of excessive intravenous fluids, especially excessive intravenous dextrose. Another scenario, a case after abdominal hysterectomy, complaining of vomiting and severe gas pain, and the abdomen is distended but not tender, and the pole sounds are absent. So this is areas. What is the most likely electrolyte imbalance? Yes, vomiting, yes, and hypokalemia. It's an hypokalemia. This is another question asked before in the recalls. A 55-year-old woman who is being treated with a diagnosis of small lung cancer presents with excessive polyuria and depression, and urine showed red cells plus. What is the electrolyte imbalance?
Hypercalcemia.
Yes, exactly. This question was asked before in the recalls about 3 times or maybe more. Case of cancer, I have polyuria and depression. As I know that hypercalcemia is very frequently with cancers, and also manifestations here confirms my suspect. So this is a case of hypercalcemia. Another question also which came I think twice in the exam before, what electrolyte imbalance can cause paralytic ileus? Of course, the hypokalemia. So, like we can see here, about 9 times or more than 10 times asking about hypokalemia and hypercalcemia, so they are of extreme importance. Regarding the fluid balance, we know that the total body water is about 60%, and 1/3 of the total body water is extracellular, divided by percent as plasma and 75% of them as interstitial fluid, and the 2/3 is intracellular. The fluid loss has 3 main components. This is very important. From urine, daily loss of 1,500 milliliter. The insensible loss, meaning the fluid loss from the sweat and lungs, is 850 milliliter, and from the stool or the feces is about 100 milliliter. And the last slide in this part of the acid-base and fluid imbalance is the definitions of anuria oliguria. The anuria is less than 100 milliurine produced in 24 hours, while oliguria is less than 400 but more than 100 milliliter per day. Normal urine output is 0.5 to 1 milliliter per kg per hour, and in infants it's 2 milliliter per kg per hour. And the put is considered loss of more than 3 liters urine production per day. So these definitions also are very important. Our second topic for today is interpretation of urodynamics. This is one of the important questions. And the last 2 years now, each exam has at least one scenario of urodynamic interpretation, and also another question maybe in clinical management part or in the pharmacology part about treatment of bladder disorders. So the RCOG now is focusing on this point, and it is of extreme importance to know how to interpret a urodynamic chart and also to study the drugs or the treatment of bladder disorders. Session we will just only the interpretation of the chart. Some definitions to know. The first one is urinary incontinence, urgency urinary incontinence, the mixed urinary incontinence, and the definition of the overactive bladder. Stress urinary incontinence is involuntary in cases of effort or exertion or on sneezing or coughing or anything which can lead to increase in the intra-abdominal pressure. This is what's called urinary incontinence. While urgency urinary incontinence is also involuntary urine leakage, but this urine leakage is to increase in the intra-abdominal pressure. No, it is just preceded by what's called urgency, which is a sudden, severe, compelling desire to urinate, and even it's difficult to delay. So the patient who complains of urgency or urgency urinary incontinence, he can simply complain of urine leakage after sudden severe desire to urinate, and even he tells you or she tells you she or he cannot reach the bathroom to urinate. Urine can leak even before reaching the bathroom. So this is what's called urgency urinary incontinence. And when both conditions occur in the same patient, when the same patient have stress and urgency, it's called mixed urinary incontinence. The overactive bladder itself is defined as urgency that occurs with or without incontinence, and also with frequency and urea. So overactive bladder means there is a kind of detrusor overactivity, which is the muscle of the bladder, which is called the detrusor muscle. There's a kind of detrusor overactivity, which makes the patient feels urgency many times in the day, and he frequently goes to the bathroom to urinate, and even nocturia, feeling desire many times during the day and night. And the overactive may be or may not, may be associated with incontinence, or maybe not. Maybe the urgency here is associated with leakage of urine, or maybe not. So when it is associated with incontinence, we call it overactive bladder wet. The overactive bladder is not associated with incontinence. They call it overactive bladder dry. So these definitions are very important to know. So overactive bladder, here we have an urgency, we have an detrusor muscle overactivity, and that this may lead to urgency, frequency, and nocturia, and this may be associated with incontinence or not. If it's associated with incontinence, it will call it overactive bladder wet. If it is not associated with incontinence, we can call it overactive bladder dry. This is a normal urodynamic chart. When we do a urodynamic test, we have two phases or two stages. First one, which is called the filling phase, filling the bladder with the fluid, and the second phase is called the voiding phase. Normally, in a normal person, during the filling, we fill the bladder with fluid, and it's normal. We should find that there is no detrusor activity, increase in the bladder pressure, and of course there is no increase in the abdominal pressure, except if the patient does any maneuver like coughing or sneezing or something. And during the filling phase, when we ask the patient or the person to do any maneuver like coughing, sneezing, or anything which increase the intra-abdominal pressure, we can see that the increase in the intra-abdominal pressure will be normally reflected on the increase in the intravesical pressure, or the pressure inside the urinary bladder. But at the same time, the detrusor muscle is still with no activity. This is in a normal, completely normal person. And during the void phase, and when we ask the patient or the case or the person to void, this is the only time we will find is a rise in the detrusor muscle activity. And of course, the rise in the detrusor muscle activity will be reflected by increase in the intravesical pressure. So this is a completely normal person. So during the filling phase, I should find that there is no detrusor activity, no increase in the detrusor activity, no increase in the bladder pressure, and of course no increase in the intra-abdominal pressure unless I ask the patient this. And if the patient do cough or sneezing or Valsalva maneuver or anything which can increase the intra-abdominal pressure, it will be normally reflected by an increase in the intravesical pressure. This is in the filling phase. In the voiding phase, this is a normal, only condition I can see the detrusor muscle acting normally. Increase in the detrusor muscle activity will be reflected by increase in the intravesical pressure, which will help the person to void his or her urine. This is the normal urodynamic chart. So normally detrusor pressure should remain near zero during the entire filling cycle until voluntary voiding is initiated. That means baseline pressure stays constant and low, and there are no involuntary detrusor contractions. This is a normal condition. Involuntary bladder contractions, this is abnormal when we find overactive bladder. We can see involuntary bladder contractions by increase in the detrusor muscle activity, which can occur with the filling phase and can be reflected by a rise in intravesical pressure. And this condition is known as detrusor overactivity or overactive bladder, which may be accompanied by a feeling of urgency or even loss of urine. Also, another importance of this test is to measure the bladder compliance. And you are not asked about how to interpret or scenarios or queries or questions about bladder compliance are not asked in the exam. The most important to know is the overactive bladder and the stress incontinence. Now let's talk about stress incontinence. Now we know that the overactive bladder means that there is a detrusor muscle overactivity, and this will be reflected by an increase in the intravesical pressure, and this may be associated with incontinence or not. This is our first part to know. The second one is what about what's called the stress incontinence. Stress incontinence means that there is leakage of urine upon maneuvers which increase the intra-abdominal pressure. And usually stress incontinence means that there is a weakness in the urethral sphincter. We have a very important parameter to measure during urodynamic, which is called the abdominal leak point pressure. What's meant by the abdominal leak point pressure? If a person or a patient has weakness in the urethral sphincters, so I am suspecting that upon increasing the intra-abdominal pressure, there will be leakage of urine. So the ALPP, or the abdominal leak point pressure, is the intravesical pressure at which urine leakage occurs due to increase the abdominal pressure in the absence of any detrusor contraction. So when I ask the patient to cough, I'm going to measure this pressure, and if there is a urinary leakage at a certain pressure, this pressure will be considered or called the abdominal point pressure. And as a consequence, the lower the pressure, the lower the value of this pressure, that means the weaker the sphincter is. For example, if we measure this, please mics, your mics, please turn off your mics, please. For example, please turn off your mics. For example, if we measure the abdominal leak point pressure and in a patient, we found that this pressure is, for example, 50 centimeter water. And at this pressure, we have leakage of urine. And in another patient, we measure the abdominal leak point pressure, and we found that at 40 centimeter water, there is a leakage of urine at the other, or patient number P. So from those two patients, who have the weaker sphincter? Patient A or patient P?
B. Patient B.
Yes, of course, patient P, because at lower pressure, urine leakage occur. And if we have patient C, for example, and the pressure was 30 and leakage of urine occur at 30 centimeter water, for example, so this patient has a weaker sphincter than the other. For this chart, also, this is a normal urodynamic chart, but I'm going to imagine scenarios at this point. When you interpret the chart or the urodynamic chart, we are going to find few features. The first one, or the first lane, or the first row, will give you the intravesical pressure, or as written in the exam. You can change the order, but note the label here before each row. Here he said pressure of the abdomen, pressure of the detrusor, and volume of the urine, and the flow, or the flow of the urine measured by milliliter per second. This is the normal urodynamic. This is the filling phase, and this is the voiding. At the filling phase, you can see that all over the filling phase, the detrusor activity remains near zero, or constant and low. And the examiner asks the patient to make anything to increase in the intra-abdominal pressure, like coughing or sneezing or something. You can see that the intra-abdominal pressure rises. This is reflected by an increase in the intravesical pressure at all these points. This is very normal. And at the same time, look at the volume of the urine. As you can see here, there is no urine leakage. So this patient is normal. When you see the detrusor row here, or the detrusor lane here, you can see that there is no activity, so there is no overactive bladder. And when you see that the increase in abdominal pressure is not associated with increase in the urine volume, or urine flow. So this means that this patient is normal. He doesn't have overactive bladder, neither stress incontinence. But let's imagine a scenario. The first thing is that when you ask the patient to cough, you see a rise here in the volume of the urine and the flow of the urine. So this is the first scenario. What does this mean? Yes, this means stress urinary incontinence. The second scenario, which is asked frequently in the exam, that during the filling phase, you can see rise in the detrusor activity here, and this is reflected by an increase in the intravesical pressure without any increase in the intra-abdominal pressure. This means that there is
Overactive.
overactive bladder. Which type or which subtype of overactive bladder?
Dry.
Yes, dry overactive bladder, because it is not associated with leakage of urine. But if it is associated with leakage of urine, it will be considered active bladder. Okay? So this is simply how to interpret the urodynamic graph. Of course, in most of the exams, he just asks you about the overactive bladder. He doesn't ask about the subtype. But this is an extra information because this classification is in the NICE guidelines, and maybe if he wants to like raise the level of the question or make it somehow harder, he can ask you the subtype. So to be in the same side, we should know both subtypes. This is another chart, another normal chart. This is pressure, this is a vesical flow, and as we can see, we can change the arrangement of the lanes or the rows. So you have to look carefully at each title before the start of each row or each lane, and we can see that this is a filling phase. And as we can see here, this is a detrusor muscle. All over the filling phase, it is constant. The abdominal pressure, only when the patient is asked to cough something to abdominal pressure, this will be reflected by an increase in the intravesical pressure, flow, or increase in the volume or flow. But during the voiding, this is very normally we can see here that the detrusor muscle works at the voiding phase, and also here the patient is asked to strain during voiding, and the increase in the intravesical pressure. This is a very normal urodynamic chart. Also, you can notice an increase in the detrusor activity in this filling phase. This is considered overactive bladder. Of course, this will be reflected by an increase in the intravesical pressure. And if there is leakage of urine during the overactive bladder, it's called overactive bladder weight. If the patient is asked to cough or sneeze and you can notice leakage of urine as stress urinary incontinence, maybe you can find symptoms. This is very advanced to interpret, but also simply because you know the rules, you can answer it easily. Maybe at the same person, you can see the detrusor muscle overactivity and stress incontinence at the same time. But this was never asked before in the exams. Now, 42-year-old with frequency, urgency, and urge incontinence, no stress incontinence. Bladder diary showed low compliance bladder. Ultrasound is normal. No improvement in symptoms with bladder drill. What is the next plan?
Antimuscarinic?
Yes, I know this is not explained before, but according to when we have a case of urgency or urgent, by another meaning, if I have a case of overactive bladder, the first thing, the first line of treatment is what's called bladder training or bladder drill. And if bladder drill fails to improve the symptoms, I'm going to provide pharmaceutical therapy. And the first pharmaceutical therapy to be used in treatment of overactive bladder is the antimuscarinic drugs. And the new generation drugs are the beta-3 agonist drugs, which is called the mirabegron, which is a new era now in the treatment of the overactive bladder. And also because of the low side effects of this new drug, it taken many attention now, and that's why it is also asked maybe every exam in the MRCG part 1 about the mirabegron, about the beta-3 agonist. Try to interpret this urogram. What we can see here, this is the filling phase, this is avoiding phase, okay? We ask the patient here, this is the abdominal pressure catheter, this is the bladder pressure catheter, this is the trouser measurement, and this is the urine. We can see that there is an increase in the detrusor muscle during the filling phase, and this is considered, of course, abnormal. We should not find any increase in the detrusor muscle activity during the filling phase. The only normal condition in which we can see the detrusor muscle working is the filling phase. So when I see that the detrusor muscle here is working, and this is reflected by an increase in the intravesical pressure, this is called
This distribution is stability. Overactive depressor muscle.
yes. The answer is the detrusor muscle over activity. Okay?
Yes, clear.
Okay. Of course, we can notice that there is no flow of urine during this condition, so it is not associated with okay, so this condition is not associated with incontinence. Why we didn't choose the detrusor muscle instability?
Because this is associated with the increase in vascular this bladder pressure.
Yes. Let me say something that some references can use these two terms interchangeably, okay? Some references refer to the instability as the overactivity. But actually, to be more specific, overactive bladder is usually associated with an increase in the intravesical pressure. But the detrusor muscle instability, you may see like some contractions like this, but without increase in the intravesical pressure. So this is the difference between the instability and overactive bladder. Also, this question exam, this table illustrates the bladder diary of 48-year-old woman who is a teacher, complains of urinary urgency and leaks urine if she is unable to reach the toilet quickly. Since she was unable to make her voice, she was asked to put a ticket in the column each time she passed urine. One day of 3 days charting shows that the daytime frequency 12 times in 24 hours, nocturia is twice in 24 hours, leakage with urgency occurred once in 24 hours, the fluid intake is 1,450 milliliter made up of 6 cups of coffee and a pinch of ginger. So what is the correct interpretation of this urinary diary?
Excessive fluid intake.
Excessive fluid intake, you see that to drink a liter of fluid or liter and a half of fluid per day is excessive intake? No, I don't think.
No.
We drink
Gradual
sufficient.
overactivity.
Yes, we have symptoms here. Even if you drink much water, it will not leak frequency of 12 times per day, nocturia twice in 24 hours, leakage with urgency. Of course, these are symptoms of overactive bladder sweat. Okay, so the best answer here is bladder overactivity. So this is simply how to interpret the urodynamics and arterial blood gases. I hope understood these two topics. Thank you for careful listening, and if you have any questions, please do.
Thank you, Dr. Helmi. You are great. You helped us a lot.
Thank you.
Thank you.
Thank you so much.
Thank you, sir. Thank you so much. Thank you, sir.
You are welcome. Dr. Hassan, are you here, Dr. Hassan?
Yes, I'm here. Thank you, Dr. Helman, for such a nice session, and it was a very good topic. I hope the students get good benefit from this.
Thank you, Dr. Hassan. I hope so.
So we'd like to have some views from the students for this.
Is there any other review? Is there any other session coming up?
Sir, can I ask one question, please?
Yes, please ask.
My question was about your course which you are going to launch, because I started studying just 20 days back, and I really don't know how to proceed further. So as I'm lacking the time and I have not studied at all, I would say just 30-40% of the course I have covered so far. Should I go with the July this thing and with your course, because I'm really confused as of now. I'm very nervous as well.
I have the same.
You ask about do you want to prepare for you will start preparing this month or not?
I have just started preparing, I would say end of April, somewhere on 21st of April.
Yes.
And so just 20 days I've started preparing, and I've just covered 30% course. 70% course is still left. And though I've already deposited my fees and everything, but I'm really not sure how to proceed further.
Okay. So, Dr. Henry, would you like to answer? Or should I?
Okay, Dr. Hassan, you can proceed if you have, if you want to answer, it's okay.
Okay. No, please, first you. I will give some suggestions afterwards.
Something.
Any idea, should I go for only recall? Sorry? Should I go for recalls and MCQs only now, or should I go through study all theory as well?
You said how many percent you covered?
30%, hardly 30%.
Okay. First, let me tell you something. Can you refund your money now? Of course
No, I
not.
can't.
Okay,
Yeah.
so
No,
are
I'm
facing
nervous.
now a real situation. Okay.
Dr. Helmi, your voice has gone.
Would be enough. Okay. First,
Yes, that's my question.
yes, you should focus on the important topics. You are not going to study all topics these days, of course. You are going to focus on the important topics. And simply, I put some posts in the part one MRCG Guide group, just telling the important topics in each part. The second thing is that you should, of course, memorize the recalls by heart, because at each exam you are going to face like at least from 45 to 50% of questions which are repeated. Okay, not only not mandatory to be repeated literally. Okay, but of course the ideas are repeated. Maybe some change in the scenario, maybe some change in the head of the question, but you are going to capture the idea of the question from the recalls. So answering the recalls plus the question, the online question banks plus the books, all this of course will give you about 60 to 70%. Okay, plus reading the most important topics listed before, and also that's why we have also are launching this crash course, because we know that some people, because of their family life, because of their work, they have much shortage of time in preparing, and that's what we are going to make in the crash course, as Dr. Hassan will explain in details later, that we are going to not illustrate in details. We are going to provide you with already recorded lectures of detailed illustrating of the theory, plus new lectures. We are going to answer most of the recalls and the important questions, and listing the points to cover or to revise in the remaining time. So you can listen now to the Dr. Hassan explanation for the crash course. Maybe it will help you, inshallah.
Thank you,
Okay,
Dr. Helmi.
thanks.
Yes, Dr. Pooja, Dr. Helmi said very well. Don't lose your heart. Don't get disheartened. Still, you have 45 days. And if you work hard in these 45 days, we are pretty sure you will be able to crack it. Uh, in our previous courses, we had similar students at the same stage where you are standing. But because of their hard work and our, you can say, guided path, they cracked the exam. Even few students, they failed the exam 5 times, and we give them a precise information, and they clear it. So still, you have time. You have to decide that you have to clear this exam. Once you are motivated enough, you will do it. So I will begin now with a brief explanation of this course, and after that, this session will be over. Okay, so let's begin. Firstly,
Yes, please.
what exactly crash course is? Its concept is to have a quick revision, because mostly students, they are preparing for this exam since last 2 months, or you can say from the last month. So the main theme is to give them an option so that they can have a quick revision with us under our guidance, and it will be an intensive course. From intensive word, I mean to say that we will be watching the students in the study room Facebook group, and they have to participate actively according to the schedule. I'll show you in the next slide, and we will make you ready for the exam before the real exam. And for July candidates, it's very good. Um, its features are live sessions, the like the similar session you are having today. It will be like this on the same platform. We will be having the session. Plus, we will give you access of the recordings of regular session course. Let me tell you one thing. Basically, in Med Exam Expert for MRCOG Part 1, we have two type of courses. the regular course and the crash course. The regular one is of 3 months, and in that we divide all the subjects of RCUG curriculum into weeks wise. So we also add them to a special Facebook group in which mentors and they interact in all these 3 months, and we make them prepare for the exam. So in those sessions of the regular, we are explaining the content in very detail. So you will get access to the recording of those lectures. Plus, you will also give you access to the topic tests. And at the end, you will have to perform the mock exam. And study room, as I explained, is the Facebook group which we will use for this group. So this is basically the schedule which we will follow. We have divided the course into 5 units. As you can see in the unit, we have physiology and endocrinology, and its session will be on 1st of June 2018. We have mentioned time as well. Then in you can see, I would like you all to, if you can mute the mics, and at the end of this section, I will open the question session. Okay, so as you can see that we will have first session about unit 1 subjects on June 1st, 2018. And then for the next day, till 7th, you have to study from the book, plus participate in the Facebook group, the study room. And meanwhile, in these days, you have to attempt the topic test of physiology and endocrinology as well. So you will complete this unit and then move to the next one, and so on. In these 25 days, you will cover all the subjects. At the last, you can see that we will have a session. We will have a mock exam, final mock exam, which is on 26th of June 2018. So it's a very fast pace course. You have to, as I told, active and do the tasks according to the schedule, because now there is no further time for lagging behind. Okay. So before every session, live session, let's suppose if you have a session of Unit 1 on 1st of June. Before that, you have to go through the recording of physiology and endocrinology on our website. You will go through the recordings which we will give you. And in the live session, we will be discussing recalls and important SPAs with the mutual active participation of the students. So this will help you understand how to solve the SPAs and how to choose the correct answers in a better way. For convenience, we will record all the sessions, and if by any chance you miss the session, you will be able to see its recording very next day on our website. Those students who will sign up with us, we will guide them in detail how to use our website and all other technical tasks. Okay, so this is the recording section of our website, which I explained before. Basically, you can see that we have recordings of all the subjects in the different sections. So you will get access, and before every session, you have to listen to the recordings so that you have a good knowledge of that subject. Otherwise, you won't be able to participate very good in the SPA practice. We will focus on the recalls, the past paper recalls, because we have observed that most of the time paper is approximately 50 to 60% similar to the past paper recalls. So this will help you a lot in clearing the exam. Recalls are though available, but some are partial, some are with the wrong answers. So students are mostly confused. So we will discuss the important ones here in the session with details and the correct keys. Okay, so next, the main feature of this course are the topic tests. We have approximately a question pool of 1200 SPAs, and we distribute all those questions into different topics. So in this course, you will have access to these all the tests, and you need to complete those tests according to the schedule. At the end of the course, we will have a final exam. It will basically the two papers. Each paper will be of 2.5 hours duration, and the exam will be very near to the real one. The final mock exam, you have to sit for like in 2.5 hours separately without interruption, and then have to attempt, um, just to have a feel of the real exam. So this thing, once you will do practice here with us in this platform, in this program, so you won't be hesitating in the real one, because you are doing a mock here. So okay, so this one is basically the Facebook group I talked about. We usually call it a study room, and in this we will add all the students plus the mentors, and we will be having single best answers discussion, plus we will notify the students about the important points, highlights, and any other notifications. So it will be, you can say, a centralized platform where we will be communicating on daily basis. Okay, so let's summarize this one. Basically, this crash course fee is 260 US dollars. Dr. Helmi will be the course mentor. Its duration is 25 days, and it will start from June 1, 2018. Course registration deadline is 31 May 2018, and we have an early bird discount for those students who will register before 18th of May 2018. If you register before this date, you can avail 15 discount. You will be paying 245 US dollar, and we also have a group discount. If any two or more members will join us as a group, then they can also avail $15 discount. So this is the now let me explain the procedure how you can join this course. The first step is to create an account on our website, www.med-examexpert.com. Account on this website, then you can just log in and proceed. Um, for each course, usually we give this the link. You can click the link, and then that particular course will appear. And after that, you can click the Get Course button to pay it online using Visa or MasterCard with ease. Okay. So the other way to join the course is to open our website and then click the course catalog section. In the course catalog section, you will see on the right side, we have categories. Click MR Suji Part 1 Crash Course, and you will see this one. As you can see that its price is 245 US dollar, and it will remain same till 18th of May, and after that it will become 260. So because it has an early bird discount, so that's why its price is less here. So this is our official Facebook page. Like our page for the latest update about the courses, exam, and the news, as we are continuously working on it. And tell your friends as well. That's all for the crash course. Now I will be happy to answer your questions.
May I ask a question, please?
Your voice is a little low. If you can increase the volume.
Can you hear me now?
Yes, perfect.
I want to ask that how long is the duration of that live session of the lecture on
Okay.
average?
Each session will be of approximately 4 to 5 hours.
Okay.
Yeah,
Okay,
and there
thanks.
will be basically total 6 sessions. The 5 sessions I told you will be according to the schedule in which we have merged the subjects like this. And the very first one will be about the course orientation, that how you will be going to use our website.
Okay. And about the payment, if we are paying through your international bank account number in our city, how to go about that thing? You haven't. I mean,
Yeah,
I'm not using Visa
basically,
or Visa card.
yeah, we have two options. You can also you can pay either by our online payment system, just using your Visa or Mastercard or any card you're using for internet purchases. Or if you want to send the payments to our bank account, we can also share you with that. You just have to drop a message on our Facebook page or on our email, and we will further guide you about that.
Sir, I already have that information about your bank account number, but I'm just asking that I have to make an account first and then submit the fee, or what?
You can just simply go to the bank branch and then tell the our account details to them. They will make a draft for it, and they will take a payment from you, and that's all. No need for have a special bank account. You can just walk into the bank branch. I will ask team to drop you a message for further guidelines in details.
That will be great, sir. Thank you.
Sure. Anyone else, please? We will try our best to conduct such sessions, but the problem is that our team is very much engaged in the courses, and sometimes it gets very hard to spare some time. So I will suggest those students who are appearing in July must join this course. It will help you a lot. You must be doing your preparation from several months or few months. So now it's a time to have a quick and good quality revision, and this course will give you a way for that. So if you have any questions, we can discuss. Otherwise, let's close the session. We have a question from a session member: procedure to eligibility form. Actually, no name is appearing. So we conducted a session approximately a month ago, and we explained in detail about the procedure. If you can drop a message on our Facebook page, and our team will send you the YouTube link. We have also have a YouTube channel on which we have uploaded the videos, the important ones. So you can just use that to see the procedure. Okay, so I guess that's all. We don't have any questions. We hope that you liked the session and it was beneficial for you. We are really happy to see you all here, and it was a very nice discussion. Yes, Dr. Helmi. So let's say goodbye.
Sir, that's very helpful. Thank you, sir.
You're welcome.
Thank you so much. Thank you so much for
Thank
listening to
you
us,
for joining.
and I hope you enjoyed the session. Yes.
Thank you and best of luck for the exam. See you soon. Bye.
Thank you.